please welcome again Dr. Mohammed Algamdi, who will be talking about IPF local evidence generation in Saudi Arabia. I can't highlight how much important is that we are focusing on real-world evidence generation in our country. Please welcome Dr. Algamdi.
يعطيكم العافية جميعا, and I'm happy to be here again. We have finally had our first IPF-related database. It's fresh, it's recent, it just got developed, and in our mind, we have these three main goals to look after: determining the IPF key characteristics to assess the disease burden and the impact of the disease, both on the level of the patients, the society, and healthcare system, and to determine the IPF natural history and the outcome. Hopefully, by analyzing the data and coming with answers, we will be able to inform the stakeholders, the managers basically, to improve the care and the services based on the result of the data that we collect, and this will ultimately lead to better outcomes. The data or the result of the studies that we will eventually conduct will hopefully inform the lung experts. It will enable us to form our own IPF-related guidelines, and that is also expected to be generated and distributed to all the primary care physicians and pulmonologists, and hopefully leads to early referral to ILD center, early commencement of treatment, and better outcomes. We have already talked about the importance of early referral. One of the studies that I have came across have shown that with every year of delay in referring patients with ILD, the mortality actually worsened. This is how our data that we are currently collecting looks like. It goes over multiple domains. Each of the domains will serve its own purpose. So we look into patient information. Here we have basically the age and the name and the MRN. We do have demographic data that we collected. It includes the patient age, the smoking history, the BMI, height and weight, and the likes. And then we have the visit date, which is a key component of the data. We have shown in the previous slide that multiple outcomes are related to the date of the visit, like time from the first visit to referral to the ILD, time from the first visit to the commencement of treatment, etc. The data will also include diagnosis. So that's include the date of the diagnosis and age of the diagnosis. We also collect data about the symptoms, mainly shortness of breath and cough, and the date of the first symptoms. Again, it will help us later on to conduct some studies and looking into some outcomes, including date from the first symptoms to the first visit at the primary clinic, and then from the first symptoms to the first visit with the pulmonologist or the expert, to be able to look and see whether there is delay in serving these patients versus not, like what happens in the previous studies that my colleagues have demonstrated. We are expecting that there is a huge delay in the kingdom, and I believe that it will be worse than what we have seen in US and United Kingdom in the previous lectures. We will go over we collect also the risk factors, basically the gastroesophageal reflux disease, smoking, family history, etc. We collect data about the comorbidities. We know that IPF patients may concurrently have comorbidities from the get-go, from the first visit, and they may also develop it over the time. So extreme surveillance and meticulous care is required during the first visit and later. Physical examination is also recorded. Lab tests are also recorded, including the connective tissue disease lab work. We document the CT pattern and the date of the CT, and the physiologic tests that are being conducted are also collected, especially the FVC, the DLCO, and the 6-minute walk test. The main procedures that we document are the bronchoalveolar lavage and the lung biopsy. The histological pattern is also recorded if biopsy is done. We define the disease stage as illustrated in the previous lectures using GAP index. It's a very straightforward score that only includes gender, age, and physiologic test. We document IBF management, both pharmacological and non-pharmacological. This will be a very important piece of data later on. It will help us to see what are the areas or the centers that have the non-pharmacological option of treatment, like pulmonary rehab, palliative care, education, and multidisciplinary discussion, and what centers are lacking those, and how we can optimize the services. It will also inform us about what centers have both medication, nintedanib and pirfenidone, available, and what centers are lacking these medications. We'll also look into the IBF outcomes, the main outcomes that usually get published in the other registries, mainly the comorbidities like PE and lung cancer and pulmonary hypertension, hospitalization, whether it is IBF related or non-IBF related, and death. Just to give you an example on the importance of having our own ILD or IBF database, this is the Canadian Registry for Pulmonary Fibrosis. For short, they call it CARE-PF. It was initiated by Dr. Christopher Risen in 2015, and they published the protocol of the database. They described the organization of their database, and they also described the data that they are going to document and follow. And after 7 years of collecting the data, it took them 7 years to collect 1,300 patients. And I was lucky to be around doing my fellowship in the field of interstitial lung disease. So we came with the first paper out of, or the second paper to be more exact, the second paper out of the registry. It was published in 2019, and we described the overall cohort in this database. So if you look at the left side of the bar graph, this is a representation of the common disorders among the overall cohort. And to the right side, it's the most common disorder in each participating sites. They had 6 sites participating to their registry. Not all the provinces of Canada were involved. And to my knowledge, there are still 6 centers to date. So, يا شباب لو سمحتوا بس الصوت. So, in terms of the overall cohort, the most common disorders, representing 80% of the diagnoses, were idiopathic pulmonary fibrosis, connective tissue disease ILD, and unclassifiable ILD. The remainder were in decreasing order: hypersensitivity pneumonitis, then sarcoidosis, then the others. We also described the baseline characteristics of the cohort. The median age was 65, 50% of the patients were male, and 60% of the patients were smoker or previous smoker, either current or previous smoker. The patients were slightly overweight, and there was a mild reduction on average on the forced vital capacity and moderate reduction in DLCO. And the surgical lung biopsy was done in 20% of the patient, and oxygen use was required in 20% of the cohort. When we look at the comorbidities, and as we demonstrated in the previous lectures, they are common among the patients with ILD. This is the Charson Comorbidity Index, which is a score that asks the patient about 18 different comorbidities, includes things like liver failure, renal failure, hematological malignancies, and other ones. A score of 0 indicates that there are no comorbidities, and as you can see in the bar graph, only 10% of the patient had no comorbidities, and the remainder of the 90% of the patients with IPF had actually one or more comorbidities. This is the first paper that comes out of the registry. We looked at the cost of workplace productivity loss in patients with ILD, and we published it in the Chest Journal, and we found a surprising result. This was the first study to look into productivity loss in ILD patients. Among the patients who are less than 70 years of age, so working age in Canada, only 30% of the patients were actually employed, and 70% they lost their job or they cannot maintain their jobs because of the significant impact of the disease that is inflicted upon them. We found that 55% of the patients either reporting presentism or absentism, and presentism basically means that you are at work, present, but you're not functioning very well, right? The average hour lost for productivity per week was 8 hours per patient, and the annual cost of productivity loss was 12,000 Canadian dollar per year per patient. And when you look at the societal or the society impact of that on the country itself, it's a huge burden. To the left side of the diagram, this is a box plot. We looked at the effect of the disease on workplace productivity, and we found it to be similar between male and female, and between patients with IPF and non-IPF ILD. So the impact of ILD is similar between IPF and non-IPF, female and male. It doesn't make a difference. We found significant correlation between cough and dyspnea and the productivity loss. So the worse your cough is, the worse or the higher number of productivity loss you will have. The more your dyspnea, or the higher the dyspnea severity, the more you're going to lose at work in terms of productivity hours. And this is why it is very important to have a comprehensive approach when treating these patients and involve the palliative care early on, as Dr. Shabrawishi have mentioned. Dyspnea management and cough management are vital for these patients. We did a similar paper investigating the same outcomes, but among patients with connective tissue disease, ILD, and we found that all the productivity loss outcomes are very similar between connective tissue disease ILD and non-connective tissue disease ILD. So just having an ILD by itself is a problem. It doesn't make a difference if you are male or female, if you have IPF or non-IPF, CTD or not CTD. The effect or the detrimental effect of the disease is there. So I just want to use the last 4 minutes to describe the ILD Center at Cluster 2 in Riyadh. This is the MOH first and currently the sole multidisciplinary program. We are serving the whole kingdom and receiving patients from all the regions and the cities. And we are designed as an inpatient, outpatient, and consultation service. Our objectives are comprehensive patient care, timely diagnosis, patient education, survival improvement, and later on ILD-related researches, inshallah. This is the timeline of our center. We started the center as a clinic at the beginning. It was in January 2019. The following month, in February 2019, we established our ILD MDD team that consisted of multiple pulmonologists, one ILD physician. Now we have become two, and two thoracic radiologists and one lung pathologist. In fact, we are three now. Dr. Agada have joined our ILD as an external physician. In December 2021, we have become an ILD clinical program, meaning that we are under direct supervision and leadership from the higher admin, and we were given KPIs to meet. In 2013, in July, we have established the ILD service line to describe what we are going to deal with, or how to deal with the referral from outside versus the referral from the cluster itself. And in July this year, we have become an ILD center after meeting all the KPIs that we were asked to follow. During this time, from 2019 to 2024, we have provided both pirfenidone and nintedanib as formulary in our pharmacy. So both agents are available in the two formats, dose 100 and dose 150 for nintedanib, and dose 801 and dose 267 for pirfenidone. We also started a palliative care service for non-cancer patients, for ILD patients, and I think we are the first to provide it, at least to my knowledge. And we have also reactivated the pulmonary rehab. It was there, but was not active, at least for the ILD patient. It was mainly dedicated to the COPD patients, so we have it now running as an active program. And we have also started an educational component of our program, and we started to have our own educator. It is true that it has certain responsibilities that are not wide, but at least we have something running. So this is our data based on an interim analysis in 2022. In June, to be more specific, more than 2/3 of our patients come from outside Riyadh, if you look at the pie chart on the right side, and only 28% from inside Riyadh. And when you look at the pie graph on the left side, the cases that comes from outside Riyadh come from everywhere, all the regions and all the cities. This diagram helped us a lot in formulating our ILD educational round. It was an effort that was between us and between BI, and we have visited several cities and conducted educational and awareness campaign. We went to Abha virtually. Unfortunately, I wanted to go there physically, but we could not. We went to Hail physically, and we went to Al Medina, Mecca, Jeddah multiple times, and we went to Al Khobar also. And inshallah, the rest of the cities will be visited in the near future. These are the most common diagnoses, and very similar to the Canadian cohort. The most common disorders are connective tissue disease, IBF, and unclassifiable ILD. This was in 2022, so you would see a higher percentage for post-COVID, so it's 5%, but now they have become diluted, and they are definitely less than 1% if we do reanalysis of the same data. In 2022, we reached 266 patients. In 2023, mid-year, 338 patients, and now we have exceeded 400 dedicated ILD patients. We have confirmed the ILD diagnosis in 89% of our patients, and we were able to exclude 11% of the cases as not ILD, and that's based on a referral from a pulmonologist. And I think that's a good number. To be able to exclude 11% of the referral from pulmonologist as non-ILD is just it's a good number. It makes a difference to the patient's life and probably and prognosis too. We did MDD for more than 80% of the cases to make the diagnosis, and that's satisfying the standard, the global standard. 50% of the patients were male. Age was 60, so just 5 years younger than the Canadian cohort. 2/3 of the patients are on ILD medication, whether they are antifibrotic, anti-inflammatory, or both. And unfortunately, 40% of the patients are already on oxygen. This is a sign that the referral is being made lately. So these patients are not being referred early on. 40% is double the percentage of patients on oxygen among the Canadian cohort. 11% of the patients have already been referred to the transplant center. It used to be King Faisal Specialty Hospital alone. Nowadays, we have the National Guard Hospital. They started their service a year ago, and they are doing very well right now. They see the patients within very short time. and they are providing an excellent care. We have transplanted so far 4 cases, and alhamdulillah, all of them are still around. These are the KPIs that we have met. We don't need to go over them, and thank you very much.